Welcome, everyone. I'm Catherine Lavender, the Data Project Manager for NACDA, and this is our Data on Aging podcast series. NACDA is the National Archive of Computerized Data on Aging at ICPSR at the University of Michigan and is funded by the National Institute on Aging. NACDA's mission is to advance research on aging by helping researchers to share and discover a broad range of data sets for secondary analysis. NACDA acquires and preserves data relevant to gerontological research, kind of like a data library, curating the data as needed to promote effective research use, and disseminates them to the research community free of charge. By preserving and making available the largest library of electronic data on aging in the United States, NACDA offers opportunities for secondary analysis on major issues of scientific and policy relevance. The focus of this podcast series is to connect with the gerontological research community. We will highlight data resources, researchers, and principal investigators in order to talk through data concerns as well as learn the stories behind the projects. You can find out more about NACDA and ICPSR by visiting nacda-aging.org. Today, our guest is Dr. Deborah Levine, Associate Professor of Medicine in the Departments of Internal Medicine and Neurology and Director of the Cognitive Health Services Research Program at the University of Michigan. So we're just gonna have a conversation about Dr. Levine's research. And Dr. Levine, why don't you talk a little bit about the studies you're currently working on and just what really sparks your interest with these studies?
Yes, thank you for having me. So my primary research focus is on preventing stroke and dementia and reducing health disparities. And so I'm currently working on 3 projects. One project is looking at how blood pressure levels over the life course influence cognitive trajectories. I'm also have another study looking at the effect of vascular risk factor levels on cognitive trajectories and dementia risk. So you can hear a common theme is trying to understand how vascular risk factors influence cognitive trajectories and reduce dementia risk, because those are promising strategies and modifiable risk factors that could reduce dementia risk in adults. I also have a third study looking at the quality of care for patients with pre-existing mild cognitive impairment compared to those with normal cognition after suffering heart attack or stroke.
Cool. What made you focus on dementia and health disparities?
Yeah, so I, in my medical training and clinical work, I have worked with underserved populations and have always been interested in reducing health disparities. When I became a researcher, I first chose stroke as my area of focus because of both a family history of stroke and also being enthusiastic about preventing stroke in my patients when I was in private practice. And so that naturally lent itself to wanting to study the impact of stroke on cognitive trajectories and dementia risk, which was my first funded project.
Yeah, that's interesting. So, yeah, I think that we first noticed your work through some university resources that were shared, some articles that were shared about your research. And I think that you were using the regards data. And then we talked with you, when we introduced you to do this podcast with us and found out you had a lot of experience with HRS and just a lot of experience in general accessing different data resources. And so if you could talk a little bit about those studies and your work and using these data, discovering these data, using these data, compiling them together, and just maybe give other data users out there an idea of what it takes, to successfully work with secondary data.
Yeah, so these are all excellent questions. So, the first step is to develop a focused research question, and that can be, spurred by personal clinical experience, research reading, but, developing a studyable, that's a word, research question that excites you. It will, help keep you motivated during the challenging or slower times of the research process. And then the second step is to find, one or more data sources that are ideal to answer the research question. And one issue or challenge with secondary data analyses is that the data are already collected, and so we as researchers have to live with the data that is collected, unless we're going to propose, ancillary data collection to augment the existing data. But assuming one's going to use secondary data, it's important to find the research studies that can best answer your research question. And there may be trade-offs between, data sets that maybe have excellent information on your primary dependent and independent variables, but maybe don't have as robust the depth of clinical data for covariate adjustment and risk adjustment. And these are the trade-offs that we have to make. And often, using multiple data sets, either to study this research question in each, to demonstrate the consistency and robustness of your findings, or by pooling data across multiple sources, which reduces the, in doing pooled cohort analysis, which reduces the chance that your findings are, due to bias, are productive ways to, answer your research question, and with the limitations of specific individual data sets.
Yeah, I think with everything you just said, the thing that stuck out the most is make sure that the research subject that you're interested in is going to get you through those challenges, so that, during those hard times, you stay with it. And I'm just kind of thinking about some of the research that you mentioned at first about dementia, and some of the talk about secondary data. So for some of your recent research, did you collected primary data for that, or did you mostly use secondary data? Or
yeah, so for the 3 studies that we're actively doing, most of the analysis is most of the analyses are secondary data, but for the study with on mild cognitive impairment, we're doing some primary data collection also with surveys at the state and national level, as well as qualitative interviews. So
yeah, that's great.
For the studies looking at the effect of blood pressure over the life course on dementia risk and cognitive trajectories, and the study of vascular risk factors, levels after stroke on the risk of cognitive decline, and dementia risk after stroke. Those 2 studies are using pooled cohort analyses. And so that involves obtaining the necessary study approvals and developing relationships with the existing cohorts, and obtaining research funding. And then, if that all is successful, then obtaining the data and harmonizing the data across all the cohorts to essentially perform an individual level meta-analysis.
Yeah, that's,
so
you have to be dedicated and detailed and thorough.
Yes.
So
yes. And that brings up another excellent point, which is the importance of obtaining the original data documentation for how all of the data were collected, how any measurements or tests such as cognitive tests were administered, how they were scored, and stopping rules and all of that, and also the importance of really being fastidious and careful about reading the data documentation, knowing the data, as well as partnering both with collaborators from the cohorts who know the data well and who actually did the work of collecting the data and writing the grants to support that work, and also people with investigators with content expertise in specific areas. And for this work, the importance of partnering with neuropsychologists who have expertise in how to administer, score, and interpret cognitive tests is essential, because then we need that fundamental understanding, and also their guidance on how to harmonize different cognitive tests across different cohorts. So the cohorts, many of them were developed for cardiovascular risk assessment, and have added cognitive variables over time. But the cognitive tests that were administered by each cohort differ across the cohort. So it's really critical to have expertise from neuropsychologists on how to sort the cognitive tests into cognitive domains, such as general cognitive performance, executive function, and memory, and then how to at the detailed level, how to handle any differences in test time given for specific tests that might differ across the studies and that kind of thing.
Yeah, I think that's a really great point. And it, it reminds me, like in some of the work that we do, we have to remind data users why it's so important to read the documentation and read the code book, because people did a lot of work, went through a lot of the details to piece together the information, collaborated. We achieve great things together, and then they put it, hopefully, ideally, for the best studies, they put it in this documentation that's available for people to read and find out about the process and make sure that they're going to be using the data that's best for them, that the data that were collected meet the intentions of the research subject that they're investigating. So, and it takes a lot of time to do this. And, a question that comes to mind is just about how much time should researchers expect to spend on paperwork and administrative tasks, all the little things that go into the process before they can even get the data, for especially restricted data collections. Publicly available data is more of a registration process, and then you can just download it, and it happens fairly quickly. But I think a lot of people get discouraged trying to access data, and they might give up. And it would just be good to hear your opinion on this, about the investment that it takes and the time and those expectations.
Yeah, so it's definitely, it does take time. It's worth it in the end to get the rich data. Sometimes the publicly available data sets from these cohorts don't have the cognitive data. And so one needs to partner with the cohorts and get the data, work with them in collaboration to use their data rather than use the publicly available data such as on BioLink. So it is an investment of time, and one has to be organized, and having project management and research assistant support can be very helpful. I mean, many of the cohorts paper proposal or ancillary study proposals are similar, so that once one has, drafted one, one can, there is some efficiency in completing the other forms, but each cohort differs in their procedures for applying to do an ancillary paper or study, and the levels of review that occur. So it's just, one has to, understand that and respect that, again, they've invested the time and effort to, seek out and obtain the funding for these cohorts, many of them that have been going on for decades, and collected really amazing data that has informed our understanding of cardiovascular research, cognitive health, and many other medical conditions in the United States. And so they want to make sure that the data that they've collected from their participants is used accurately and appropriately. And so that's why they have these procedures in place, so that the science is the best science, and that the the participants who have given their time to participate in these studies for decades know that their data is being, and information is being used appropriately.
Right. Thank you. Yeah, I think that's really helpful. There's just, it's just so much effort that goes into making sure it's a successful research process, successful and ethical, and what's the other word I'm thinking of? Just making sure you have accuracy throughout all of it, and hopefully there's support in the background with all of these projects. For instance, with NACDA, my director, James McNally, and I are both support, as well as staff from ICPSR, to obtaining restricted data from ICPSR and NACDA. But I am not sure about other centers and their support. But I do think, talking with some other people, like from NCHAP, and which we work with them to provide support, but also like PSID or HRS, I think that there are contact people behind accessing those data, and hopefully just getting a hold of somebody can help those people who it's their first time. But let's see. Another question that comes to mind, because you're talking about different data sets, different cohorts, and being thorough, there's a multi-study cohort research perspective that you're referencing, and it seems like that's become less used in recent years. And so what do you think are the strengths of this approach?
Yeah, so the strengths of the multi-cohort or pooled cohort analysis are that one can answer questions that were previously not possible with individual cohorts. So it might be that one is, and that's primarily based on a sample size issue. So depending on what your sample population is, there may not be sufficient numbers in one cohort, but by pooling them all together, one has sufficient sample size. And the other also is to look at, if one's interested in looking at effect modification, or within subgroups, such as we have looked at differences in cognitive trajectories by sex and by race, ethnicity. then again, having a larger sample size is required to be able to make valid inferences from the data. And so by pooling the cohorts, one is able to have that sample size. And also there's increased generalizability by including different cohorts and that are, have different populations to arrive at, to study a research question.
Right. You get a bigger picture instead of just a snapshot, and you don't have to wonder as much if it's a coincidence as opposed to actual, data, actual where you can make inferences with confidence. Yeah.
Correct. Yeah. Your certainty about whether the association is in fact significant or not significant is improved by having greater sample size and multiple cohorts. It's similar to how we do meta-analyses of clinical trials. So individual clinical trials are informative when there are multiple clinical trials that find the same result. That's obviously what we consider as the gold standard, the strongest level of evidence. And also meta-analyses of multiple clinical trials that arrive at the same answer as some of the stronger individual trials is important.
Yeah, thank you. Can you talk a little bit about the challenge or maybe some tips you might have for when you're dealing with these multiple data sets? And I just from my experience seeing different data sets, they each have their own weights that you have to apply in order to be nationally representative samples, or account for unequal distributions of gender, or income levels or race. And so if you could talk a little bit about that, like I said, any tips that you recommend, or just interesting ideas that might help somebody else with that.
Yeah, so so if one is going to make inferences about how their findings would extrapolate to the national population, then one has to use and provide national estimates. Then one does have to use the weighting, but we have and certainly that's important when using any of the data from, let's say, the National Health Interview Survey or BRFSS, or one can do that with HRS also. But for the cohort studies, many of them are community-based. So thinking about, some of the cardiovascular NIH-funded cohorts, such as Framingham or ERIC or Cardia, they are community-based. And so one does not, we don't try to extrapolate those data to any kind of national estimates, so we don't need to weight those. But it's very important to be organized. So we have created, spreadsheets for our key dependent and independent variables and covariates, where each cohort is identified with the data set and the variable name and the response categories. And then we come up with definitions for how to harmonize the variables across the cohorts in collaboration with the cohorts. And so that level of detail is very helpful for all involved, including the investigators, the data managers, and the analysts, and the biostatisticians, so that we all know it's sort of like creating a data dictionary for the pooled cohort. And so that's very, very important, and helps you really understand the data and know how each individual variable is collected by the cohorts before you harmonize them. And that's just very important. And again, going back to the data documentation. And then another tip is to be aware of the timelines and procedures for the cohorts. So some cohorts require that a paper proposal is approved before one can submit an abstract to a meeting, and some cohorts require that the abstract is reviewed by the application committee of the cohort before it's submitted to a research conference. So one just has to be aware and follow the procedures of each cohort for submitting abstracts, paper proposals, study proposals, papers, kind of thing.
Right. Yeah, I think
And
those are
budget
very
that into
helpful
their
tips.
timeline.
Yeah.
Yeah.
Yeah, definitely brainstorming, making a timeline beforehand. Those sound like great tips. Thank you. And I think we're gonna, start wrapping up here. We've got another question for you. And after this, if there's anything else that you want to, make sure you talk about before we're done with today's recording, please feel free. But I think our last official question is about all the work that goes into this. It is a lot of work to go through the research process and to do this multi-cohort approach, but ultimately it seems worth it. And so how would you recommend we encourage other researchers to engage in these complex study designs with restricted data?
Yeah, so again, I think it's just coming up with the research question. And so if you have a research question that would lend itself to this approach, or you can't find an individual cohort that would really answer the question well, but perhaps by pooling cohorts, one could get to could study the question adequately, then go for it. The cohorts are extremely collaborative. They all have websites with the data documentation and all of the forms and who to contact, and they really are terrific partners. And so, and want to help people use their data to ask and answer good questions. And so it's not as daunting as it seems. And really, it's not different than any other science that we do in terms of you have to have a good research question, follow good procedures and methods, be careful, make sure you're doing accurate, valid work, and collaborate with the people who will help you do that. And so it's, the same fundamental research components that one and practices are applied to this research.
Thank you. Yeah, I think those are great points, and especially about how these other researchers share these data because they want other people to use them. They want them to discover new ways that the data are useful, and that they're willing to help provide additional details that might, have gotten missed in the documentation or anything like that. And yeah, I think that makes a lot of sense. Thank you. So
sure, and there's also, oh, I'm sorry.
Oh, no, go on.
Yeah, so and there are also collaboratives that have popped up where where people who are doing cross-cohort collaborations, share best practices, present their work, ask each other questions. So there's a lot of support out there, and both in the individual cohorts, but then among the community of researchers who are doing cross-cohort research.
Are there any meetings or networks that you would recommend if people were interested in reaching out to collaborate?
Yes, I will put them on my on the sheet that will get posted after our
Great.
associated with this podcast.
Thank you so much. Yeah, we'll have this recording out and a text version of some bio and interview with Dr. Levine on the NACDA site. And that would be wonderful if you could provide that. And is there anything else that you wanted to mention before we wrap up today?
Yeah, so one of the groups is the Cross-Cohort collaboration. And so, so it's a large group of folks, and they have different, it's so large that they have subgroups, such as one focused on aging epidemiology. And so they have regular meetings and also have provide assistance and, guidance, I should say, about, applying for studies and that kind of thing.
Thank you. That sounds great. And, if anyone listening to this has any questions or you want to follow up with us afterwards, you can email us at icpsr-nacda@umich.edu. And we can, pass on questions to Dr. Levine, if necessary and see what we can do. But we definitely will recommend this, let's see, what did you call it? Can you repeat it?
Yeah, the cross-cohort collaboration.
Cross-cohort collaboration. All right. So thank you so much for being here with us today, Dr. Levine, and to our listeners for joining us. And we will provide any links to any studies we referenced in the description for this recording. And if you have ideas about other content you would like us to feature, please reach out to that email I mentioned, icpsr-nacda@umich.edu. And thanks again, Dr. Levine. This was really helpful, and we really appreciate all the work that you've done, and that you could talk with us today a little bit about your research, but also your experience with this process, the process of working with multiple cohorts and accessing data. And we look forward to seeing more of your work on preventing stroke and dementia and reducing health disparities.
Great, thank you so much. And I'll just clarify, it's the Cross-Cohort Collaboration Consortium.
Oh, man.
And that information will be on the sheet. I know, just in case people are Googling and looking for it. So thank you.
I was thinking C cubed, right? But now it's like C to the power of 4. With that acronym, if we were to shorten it. Anyway, that was a little bit of my data archive acronym nerdiness coming out. But I think it's a great way to wrap it up. And thank you again so much. It was a pleasure to talk with you.